Okay, now it's your chance, and I don't know if we have questions that are written. I guess we do. Mark is coming up. You all know Mark Hurlbert, who's our chief, what are you, your chief visionary officer. He's like, all right. If you have metastatic disease and you're getting immunotherapy, all right, is immunotherapy the kind of thing you get like one time or a few times, or is it the kind of thing that you get for the rest of your life, or how is that given? Somebody's very curious about that.
So if you have metastatic disease and you are in this moment, except for a couple of conditions that are not breast cancer, is in a trial, so is in a clinical research protocol. If you receive immunotherapy, generally the protocols are written, you will continue to receive it until you stop responding. What is good news is that particularly in other diseases, but it's starting in breast cancer as well, sometimes we have this dilemma because the disease is completely gone away and you don't know whether you should stop the immunotherapy. And there are survivors of metastatic disease in melanoma, for instance, that have no more disease. So that's a nice problem to have, whether you should continue the same immunotherapy or stop it altogether. Very similar, I think, with Herceptin, right?
Right. Yeah, I mean, the Herceptin story is also fascinating. I got to tell you something. I think we've been doing immunotherapy all along.
Right.
We just don't know it. I mean, we just sort of don't realize that. I mean, I hope that Jose Baselga is somewhere here in this thing, but he and I, in the phase 2 of Herceptin, trastuzumab, the initial testing to see if it worked, had a patient who had chest wall disease, biopsy proven for sure it was recurrent breast cancer, who went into complete remission with chemotherapy and Herceptin, and then the cancer just didn't come back. It just kept not coming back, and a year went by, and 2 years went by, and 8 years went by, and the question is, like, when do you stop? And eventually the patient did stop, and the cancer still hasn't come back. And so, and this was flat out metastatic disease. So that there is a point where your immune system and other systems that may be involved in the biology we're using as a big grab bag take over, and the biological effect that you get is there, and the cancer is going to stay under control. I think it's going to be a big question with as our immunotherapy gets better and other things get better. Like this question here is, how do you integrate immunotherapy with other things? And I think, I guess I could throw it to Judy. I guess we're still learning, huh?
I think we are still learning. We've had time to work on the other parts. Now here comes the immunotherapy, and the temptation is to integrate it with everything. But the good thing is that there's 50 years of immunology to help us use rational thinking and not waste time with combinations that might not make sense, and so much more information coming. So, my patients are very frustrated that we don't have immunotherapy trials for each disease in each circumstance at the moment. We have perhaps the early days, but we have so much promise and many ways to go. You want to add to that, Larry? Or should we ask anybody else?
You've got a question in front of you there on a card. Why don't you
I do.
ask that question?
So this question is, my family carries mutation in a gene called PALB2. How common is PALB2 compared to the BRCA1 gene, or the BRCA genes BRCA1 and 2? So PALB2 is another of the breast cancer susceptibility genes. It was identified by David Livingston, who's a BCRF investigator in Boston.
I was looking for David somewhere here.
He's gone home, but he was here yesterday, and I'm sure he'll be back. So it's involved in DNA repair like the other genes. It is not as common as BRCA1 and 2 in the population. And so to some extent, to learn about it faster, you may have seen in the report that came to you from the lab that there was a piece of paper about joining a study to try to accelerate gaining the information. If it took us, how many years, Mary Claire? 15, 20, to put together SIMBA large collaborations or individual samples of people with BRCA mutations, because people were so good about participating in research and learning tons about how the genes behave and about what should be recommended. But now we have many more genes for breast, for ovarian, for colon, for mixtures, for pancreas, for prostate finally. And in order to learn about these newer genes faster, we have a project called PROMPT that is supported by BCRF that helps to give you all a place to donate your data and accelerate our progress in those genes so that soon we know as much as we did about BRCA1 and 2. So stay tuned, and if you don't know about the project and are interested, Ken Offit is here, Mark Robson. I ask any of us after.
Yeah, you know, I mean, there's so much interest in this topic, and we're going to be all mixing together and having lunch together. Will the folks who are doing hereditary susceptibility, genetic kind of research, or the people that are mentioned that are in the room, just stand up for a second so the audience can know who you are? So if they're sitting next to you, you ask your question. Mary Claire, come on, stand up. Ken, Mary Claire, come on,
Jeff
guys.
Weitzel,
Susan, come on, just stand up. I want everybody to see who the folks are back there. All right.
It's good now you can see all the people.
We have a collection of the world's experts in this topic. You know, all here physically in this room, international experts that have enormous amount of experience. You know, really throughout the room. So, you know, you can ask the questions individually as well. I mean, one of the fantastic things about BCRF is, you know, and the reason why we do this, by the way, is that we don't separate the scientists from other people, and we're all people. You know, we're experts in, with one exception. We have a non-human here, but I won't say who that is. But it's funny, that non-human just smiled. So but the fact of the matter is that, you know, everybody here is an expert in something. You know, we're experts in our research, we're experts in medicine, whatever. Too, you're experts in many things, including the details of your own life. And so, you know, we're a community, and that community feeling.
You can also see all the people who will be offended that I didn't mention their name. So I'm sorry for that already.
Yeah. Well, it's, you know, welcome to the club, Judy. This is what happens when you sit up here. So do you have another question there?
So I have a question. How similar are breast and ovarian cancers? So I can start, and we may ask some others to chime in. So it turns out that at the molecular level, right, BRCA1 associated breast cancers, triple negative breast cancers, and papillary serous ovarian cancers, the most common kind of ovarian cancer, are very similar. And they're very similar in some ways in their behavior. But they're not identical, and one of the ways you can tell that is, for example, by these newer drugs, the PARP inhibitors and the platinums that are used in the treatment of ovarian cancer, at least platinum for a long time, PARP inhibitors more recently. Those work whether or not people have an inherited form of ovarian cancer, or they just have ovarian cancer at least without an inherited risk we can identify, whereas BRCA1 associated tumors are treated effectively with PARP inhibitors, but so far not tumors that are not clearly BRCA associated. Now, some of these new genes may confer some susceptibility to these drugs. There may be other ways to predict, but clearly, even though they look alike, not all tumors behave the same way. So triple negative breast cancer, ovarian are similar, but not identical, and yet we clearly can learn from each other.
This links to a question that I have in front of me here, which I think just extends it, which is that people were touched by the fact that some of the people in the video had more than one cancer, had recurrent cancers, had new cancers, and very sophisticated question, really. I mean, is this recurrence of disease? Is this new disease? Is there something about their genes in their normal cells that predispose in that kind of in that regard? And I actually don't know the answer to this question. This is the first time I'm violating the law. You know, lawyers are taught never to ask a question unless you know the answer. I'm going to ask a question that I don't know the answer. I don't know if we know the answer. In terms of the molecular biology, Chuck, of cancers, when we have recurrent cancers, this comes up a lot, where somebody has breast cancer and they get treated and everything's fine, and 12 years later they get another cancer. It looks somewhat similar to the first one, but not really. What do we know about the intrinsic subtypes of recurrent disease? You're in charge of the TCGA and you're in charge of the Aurora. Do we know anything about that?
Well, thank you, Larry, for giving me the unanswerable question. Yeah. These are, and I'll start the question by saying these are really hard samples to get, right? And we don't have enough of them to really thoroughly answer the question. We do have a study with Lisa, headed by Lisa Carey, where we actually are trying to look at these samples from individuals over time, and to see how the tumors change, or conversely, how similar they are. In terms of the intrinsic subtype, it seems over time that's relatively stable, right? So if you start as a basal triple negative, in the metastatic setting, it tends to still have that phenotype. Within the luminal cancers, there can be a progression where you'll start with the potentially more indolent, what we call luminal A type, strongly estrogen receptor positive, and the ER may go down and other things may come up. And so there's a clear progression there. Again, I think our Aurora study of looking at metastatic disease is going to be the perfect place to try and get at this, right? Because in that study, basically the inclusion criteria will be to have the primary cancer and then metastasis. And those are, in most cases, separated by each other by many years. And so we will collect the data, I think, to try and get at that answer.
So, I mean, it's a great question, and obviously it's a question that we're still wrestling with because we have a lot more to learn. And the good news is we're in it, and we're gathering that information. I'm just going to throw out one more question and then have Judy do this. Well, actually, let me just make one comment about a question and then have Judy ask a question, which is is BCRF collaborating with other people who are used to using big data like Google moving forward? BCRF is a named participant in the Cancer Moonshot project that you heard that Joe Biden talk about. And as a matter of fact, when there was a summit on this in Washington D.C., BCRF's position in this area was really highlighted. The Moonshot is intending to bring together all the stakeholders to the table and to work together in a collaborative fashion to do what we've been talking about, analyze that. And BCRF is a very important component of that. We're large supporters of that activity. We just recently participated, I guess like a week ago, Mark was there, I wasn't, about a week ago in a meeting about circulating DNA and efforts to work up international standards. You could do blood tests and actually see cancer DNA in your blood, if you have cancer, and sometimes to predict if you're going to get cancer. This is a very hot and new area that we have many investigators here who are actually involved with and studying and have leadership scientific positions on. But there are different techniques, there are different ways, there's different data sets all over the world, really. And bringing that all together is really part of what the Cancer Moonshot Initiative is all about. And just to mention that BCRF is a very intrinsic part of that. Judy, you've got a question?
Yes. So Chuck, people are wondering not just about the way we look at individual genes or patterns of genes, but some of these profiling products that are out there, Oncotype and Mammoprint, and ways of trying to use multiple genes to predict behavior, particularly in hormone-sensitive breast cancers. Can you speak a little bit to where we are with those?
I think the tests you've mentioned and others have somewhat converged onto similar findings. And again, I'm going to say this is taking advantage of our ability to look at the genome and then through computational analysis, whittle it down to a smaller number of more manageable genes. And then by using a model, we can apply this to each patient and get I think a good assessment of, in this case, their baseline risk. And again, I think there is a common theme between all of these where, to get into some of the technical things, it's, there's sort of a yin-yang between the estrogen receptor and proliferation, right? And if one goes up, the other goes down. And when the estrogen receptor is high and many of its targets are high, that tends to portend a better outcome and actually portend less chemotherapy responsiveness. And then when the proliferation is high, it's the reverse.
And what is also very interesting that Chuck showed us yesterday, that for each of these cancer profiles, there may be also an immune signature. So there is also a message that comes from the immune system. So maybe integrating the two can help us tailor the treatment better.
So absolutely yes, right? So these tests continue to develop. We have new versions in the lab which do integrate the immune system, integrate mutations. The harder part and the longer part is now what we call the clinical validation, right? We can't go as fast in the clinic as we can in the lab. So now these newer versions are being tested retrospectively on patients from clinical trials. If they pass that test, then there'll be new and improved versions of some of these assays.
I have a question here. Walt, are you here? All right, stand up for a sec. Can I drink alcohol? Well, everybody knows that I can drink alcohol. The question is, should I drink alcohol and how much?
it is a complicated question. It's a double-edged sword, and there is probably a different answer for men and women on this, because there are clear benefits in reducing cardiovascular disease and diabetes with modest alcohol consumption. It's not more the better, but a drink or two a day definitely does reduce those and reduces total mortality and improves life expectancy in men. But in women, there is this trade-off that even modest, very modest amounts of alcohol consumption do increase breast cancer risk. And with long follow-up now in large studies, we can see even one drink every other day, there's about a significant 10 or 15% above baseline risk of breast cancer. And so that's a trade-off. That's probably a decision that an individual needs to make. There's obviously enjoyment and relaxation and quality of life with modest alcohol consumption. But I think that we do have the data that there is this trade-off between some benefit for cardiovascular disease and increased risk of breast cancer.
While you're standing, this is a question that comes up all the time, and the question was generally about diet and exercise, but I get asked this all the time, and I just, are there specific foods that you could eat that can decrease your risk of breast cancer? I mean, we see ads, walking here today because of the traffic, I got out of my cab and walking here, I saw 2 ads in storefronts that basically said, eat this berry and you won't get sick ever. I mean, are there specific? So I was a little late because I had to run in and get that berry. You understand? Are there specific foods? When we talk about the relationship between diet and cancer, what's your thoughts on that?
Well, we started off in the early 1980s with a very dominant hypothesis that fat in the diet was a major cause of breast cancer, and after long follow-up, lots of examination of this in long-term observational studies and randomized trials, that just hasn't been supported, that the total fat intake in the diet does not seem to be related in any important way to breast cancer risk. And we've looked at, there was also another promise out there based on retrospective studies that eating a lot of fruits and vegetables would reduce cancer risk by 40 or 50%, but again, with the long-term, more detailed studies, that hasn't held up either. But now with, again, lots of data, we're digging down more deeply, and it does seem that fruits and vegetables intake is modestly related to lower risk of estrogen receptor negative breast cancer, but not estrogen receptor positive breast cancer. So that's good news, and that's been backed up with blood studies looking at carotenoid levels as well. So I think it's maybe a small step, but it is something that over many years we've been able to say we can do something about reducing ER-negative breast cancer risk. And one area that's really exciting to me is we're just in the last couple of years, we've had enough data about diet during adolescence and breast cancer risk. And we've looked at adolescents in particular because we know that breast tissue is particularly susceptible to carcinogenic influences earlier in life. The best evidence was that atomic bombing in Japan had an effect on increasing breast cancer risk if a woman was during childhood or young adult, but after age 45 or 50, there was almost no effect of the radiation on breast incidence. And now looking at high school diet, we are seeing that higher red meat consumption is related to more breast cancer, higher fiber intake, and more fruits and vegetables are related to lower risk of breast cancer. So we've known all along this is a lifetime process, and it's very clear now, I think, that we really need to start our prevention efforts as early as possible.
Excellent. Thank you so much. Judy, I just passed you a card. Do you want to respond to that card?
Sure.
And I think there's others in the audience who probably will have views on this topic. I'm just guessing.
You think?
Yeah, I think.
This is Larry's payback for the other question he asked that I couldn't answer. So, do you recommend having a genetic test if there's no cancer history in your family and you are healthy? And should you have a genetic test if there is cancer in your family? So I can start, and then any of those people who stood up before can raise your hand, and we'll bring you a mic. You can chime in.
Right.
So, do we recommend that you have a genetic test if there's no cancer history in your family? So, this is a challenge at the moment. So it would have been so easy a few years ago to say, no, we never do. But we've learned that family history is not a perfect predictor of cancer risk. So while at the moment we generally do not test people who have no family history of cancer and are just wondering, do I have a gene? We are thinking, based on work done by Efrat Levy-Lahad and Mary Claire King, that in some populations where the risk of carrying an altered BRCA1 or 2 gene is unusually high, like in people of Ashkenazi Jewish descent, we may now have enough data to suggest that we should test everyone who has Jewish ancestry and see whether they have a mutation, since we do know so much more about how to help reduce the risk of breast, ovarian cancer, and hopefully some of the others as well. That's certainly a different way of thinking about this than we've been doing before, and we're working on things like that. If you have a family history of cancer, should you have genetic testing? Well, you know, almost all of us have a family history of cancer. Cancer is very common in our lifetimes. If you count skin cancer, men have a 1 in 2 risk of getting cancer and women a 1 in 3 risk. So having a relative in the family with cancer, that should be most of us. Maybe we should study the people who don't and figure out why not. But in the meantime, if those cancers are breast or ovarian, colon cancers, you know, increasingly pancreas, prostate, various things, certainly if they occurred at young ages, if they're childhood cancers, you might at least think about going to see a geneticist and finding out if there would be information that would be helpful for you. Most of the testing we do, we still don't find mutations, but we ask the question when we think it might help. So who would like to add to that?
Yeah, there's so much strong opinion here among our experts. Mary Claire, do you want to make a comment, or Funmi, please?
Thank you. I think if we're really serious about prevention, we have to accelerate progress in getting everyone who has a BRCA1 or a BRCA2 mutation to know about that status before they ever get cancer. Because when they do get cancer, we identify them, and sometimes the cancer is a little bit more advanced than we would like to have happen. The challenge is that the cost of testing has been too high. We haven't had good ways to communicate the different ways that women can handle their risks. And so as a result of that, we have delayed really getting people to know what to do. And so what we end up having to deal with, and this is what I deal with in my practice all the time, 23andMe already offers testing to anyone who wants it. They market it on television, and a lot of people are actually knowing about their mutation status without a well-developed structure for us to actually counsel them. So they go to Dr. Google. And we know Dr. Google can help everybody. So I think what BCRF has done is actually brought a lot of us together to begin to think about how we accelerate progress in this regard. And I think it's not really just among Ashkenazi Jews that should be thinking about this. It's African Americans, it's Mexican Americans, it's Asians, it's everybody, because these mutations are present in all populations. And for 20 years, we've known how to do the work in the laboratory, and we're just really having a hard time getting it to the population that needs it.
So, yeah, please.
Laura Van Veer, UCSF. I'm collaborating with Laura Esman, who is not here anymore this morning, and with Barbara Parker, who is here from San Diego. We started across the UC system a large study actually to use this information of genetic risk to guide women in their personalized screening. So what we're doing, we're actually testing all healthy women that come for mammography and using the information of their genetic risk, with also these moderate risk genes, as well as their risk factors to guide them in frequency of screening and what age they should start screening. So I think following up on Funmi's proposal for prevention, I think that will allow us to further direct prevention to those women who are in need of and who have a higher risk, to direct the prevention to them, and others whose risk might be lower based on all the models that have been developed, they can actually go for a more relaxed screening protocol. So I think that will help us to understand the population better of healthy women, and even guide them, if somebody gets breast cancer, how to use all that information for their treatment. So I think there is a use for it. We're currently starting at age 40 when mammography screening usually starts, but I think there will be a plea for even do that earlier on.
Thank you. I just sort of want, again, an umbrella kind of thing, just so you understand the organization that you're all part of here, is that, it's making good decisions about all these topics, screening, prevention, therapy, whatever, too, requires research to really, it's a tremendous mistake to say, hey, there's an urgent need for an answer, so we'll just come up with an answer and we'll pose it on the population and that's it. We've made enormous mistakes throughout history in doing that. The radical mastectomy is a very good example. It seemed like a good idea at the time, and so it became standard of care for a century. And it turns out that you don't need such extensive surgery to actually have the same kinds of results. And so there's this tremendous tension always between the urgency of a question and getting an answer that's really going to be reliable. And one of the really remarkable things about this organization that everybody in this room is a part of is the fact that we're doing the right research, or the research that we identify as right. And if there's a new area of research, we expand our grantees. 15 more this year because of your generosity and the generosity of many others that were able to do that. But it's not just esoteric science. It's science that's directed toward a goal and getting a reliable answer as rapidly as possible, and in the whole diversity of questions that relate to breast cancer. And you're hearing all those diverse things. One question that got asked me is how close are we to finding a targeted therapy for estrogen receptor positive metastatic breast cancer? And of course, we do have targeted therapies, again, with the anti-estrogen approaches. Tamoxifen, other drugs that are like tamoxifen, we call them selective estrogen receptor modulators, drugs that decrease the amount of estrogen in the tissues, the aromatase inhibitors that were developed and have been studied extensively by people that are in this room. And drugs that could decrease the amount of estrogen receptor in the tissues so they can't be stimulated. So all those really are available. But one of the really fascinating things about this current time is that we're learning about mechanisms of resistance to those drugs. So we can use targeted therapies, CDK4/6 inhibitor, also developed and studied by people that are here, mTOR inhibitors. I'm just throwing terms around just to identify these are real things that can shut off mechanisms of resistance. And also it may relate to immuno-oncology as well, where we can combine these drugs as well. So the next step is, and we're working on it, is how to combine therapies, looking at specific molecular targets in a rational way to get the biological effect, to prevent resistance mechanisms, so forth. So the answer is that we have targeted therapies, but we're improving them. And what I like about the question is that it's about plural therapies, which means that we're going to have to actually combine these things together. The other quick question that I just want to go through is about 3D mammography. It's being done in many places. There's reimbursement issues involved, but studies are in place to actually see the benefit from 3D mammography versus standard mammography, and in comparison to the relative costs of the therapy. This is a very tough area that you got to sort of think about, because it was like with breast screening in general. We're frequently, I've been involved in many debates and on many stages, and I've moderated many debates about the value of screening. And BCRF has a very strong position, as the vast majority of people here, that screening is a good idea. We're talking about nuances there as well. But it's a different question if you ask, what's the best public health recommendation versus what is the best way for an individual woman to minimize her risk of dying of breast cancer? You can get different answers. Because recommendations for the general public take in a lot of other considerations, economics being part of it, and availability and geographical accessibility and all those other issues, as opposed to, for an individual woman, taking everything else aside, what's the best way to reduce her risks. And those kinds of policy things are also things that are critically important. And BCRF is participating in those, and I think we're going to probably do, as things evolve further, we're going to probably be doing more of research in that area, just like we're expanding our research in doctor-patient communications and other things that are critically important. The best precision medicines in the world, if you can't explain them properly to people, they may not take them, or they may do something else. The airplane can only fly if all the pieces work together, including the most minor part, right? So that, and all the parts have to be excellent and all have to work together. And so that's really what this is all about. Judy, you got a question there? And I think we're going to open the mic to the team.
Well, the specific question really is about immunotherapy and how long you should take it. but maybe we could think about it a little more broadly. When you have new therapies like immunotherapies, how do you figure out how long you should take them, how much the doses should be, what kinds of things you can combine them with? Because so much of what we do really is not going to work if we just give one drug alone. We need to give combined approaches. Sylvia?
So there is a lot of research, in fact, in understanding standard therapies, whether it's radiation or chemotherapy or hormonal therapy, how to combine it with immunotherapy. But I also think Dr. Emmons is here, and she's an expert on immunotherapy of breast cancer, and she may want to comment. But by the way, I want to say that breast cancer came a little bit late on the immunotherapy arena, but is making huge progress, and she's a pioneer on that. But I think also immunotherapy is rapidly evolving. So we think about just the same 2 or 3 drugs, but there are so many drugs coming to fruition. So there will be enormous opportunity in breast cancer to combine with different drugs, different therapies. And certainly all of this can happen only if patients want to participate, choose to participate in clinical trials. And maybe there is a segue to this to address that.
So immunotherapy is definitely under accelerated development for breast cancer.
Just mention where you're from. So.
Yeah, Alicia Emmons from Hopkins in Baltimore. To date, the focus has really been on triple-negative breast cancer for a variety of reasons. Triple-negative breast cancers tend to have more T cells in them. T cells are the smart bombs of your immune system that can really fight tumors. And what we think, Sylvia mentioned that tumors tend to hide themselves from the immune system, so they upregulate a protein called PD-L1, which is sort of like an invisibility cloak from Harry Potter, and it really shields itself from the immune system. And these drugs act to really take this cloak down so that then these T cells that are sitting there but can't get to the tumor can then attack it. So the response rates in PD-L1 selected triple-negative breast cancers are around 19% so far. These agents are also under investigation for HER2-positive breast cancer, which also tends to have more T cells. The ER-positive breast cancers tend to have less T cells, so they're a real challenge for us. Even for the tumors that appear to respond, the tumor types that appear to respond, only 19% are responding. They're fortunate patients, but we need to get more people to respond. So the major goal right now is to figure out how to convert these non-responders to responders, and we're using combinations. So you've heard about a combination with radiotherapy. There's combinations with chemotherapy. Early data suggests that adding nab-paclitaxel or Abraxane can increase the response rate from about 19% perhaps to about 42%, or even more depending on when the patient gets it. So I think we're making a lot of progress in terms of accelerating this with combinations. It's true that a big question is how long you should continue these therapies. It looks like the people that are fortunate enough to respond have a durable response, and it's this durability of response that really reflects the activity of the immune system because it's designed to remember. And you heard about this patient case with Herceptin that had a complete response that really persisted even after the therapy was discontinued. So a major challenge for the field, in addition to developing combinations and increasing the number of responders and converting those cold tumors into hot tumors poised to respond, is to figure out how long to continue these therapies in people that are having responses. So really exciting times. I think we have a lot to learn, and we're really dedicated to making even more progress.
Excellent, thank you. There's this, one of the hot topics here is circulating DNA, which may be able to tell us, are the mutations that are associated with the cancer persisting, and might give us some hints for where to stop the therapy. And so that we ought to probably not get into that right now because we're kind of getting late in the meeting, but I think maybe next year there'll be a tremendous amount more data on this very interesting topic, and I think that might be a good time to bring that thing forward. I think we have time for a few more questions, yeah. And so, are there mics out there that are being handed out so we can have some questions from the audience in a verbal way rather than a written way? Raise your hand. Don't be afraid. Right here. Right, there's a mic right up front row. Okay.
Hey, Larry.
Hi, Larry.
Question for you on HER2 positive and tamoxifen. So historically, it was 5 years. Now it's 10 years, right? That you should be on the inhibitor. So my question to you is, why not keep the patient on it forever? And hopefully that will help. Or are we finding that 10 years, there's sort of a cliff, and then that's it?
Well, it's ER positive.
Sorry,
That's,
ER
yeah, you said HER2 positive. But actually, the author of that important paper is among us, I hope. Please stand. No, I guess not, because that analysis of longer versus shorter was really very UK based. Was really an innovation that came there, and then was really a very, very important observation. And I got to tell you, the history of it was that the thought was that a short period of exposure would be reasonable originally. So it was 1 year of tamoxifen, and then 2 years of tamoxifen, and it was only with 2 years, basically, that we actually saw a biological effect. And then we found out that 3 years was better than 1, 5 years was better than 2. And then there was a hint of some data that actually taking it longer than 5 years could actually be detrimental, and that concerned us. Trials were done that actually extended it beyond that. Somewhat courageous trials, actually, because the general feeling was that 5 years was the optimal duration. And it does seem that longer is better. There are trials that are actually extending it beyond that at the present time. But with all therapies, there's always yin yang. There's always a trade-off. Benefit versus risk, and knowing that benefit risk is really where these decisions are currently being made. And I would say that even with the 10 years, that not everybody is probably benefiting for that additional time in terms of their own risks and subjective risks. Hot flashes, osteoporosis, which could be an objective risk, as well as economic issues involved. Obviously, the longer is going to be more expensive. The good news here then is that it's still under study, it's still under analysis. It's something that as a community we're watching very, very carefully. There probably will be, as we just mentioned, a critical time where you can actually stop and you've gotten all the benefit that you're going to get. And that should be something that we can talk about really next year, is what can we do in terms of assessment of the individual to know, you're now in good shape, the therapy you've gotten is going to work for the rest of your life, it's going to have that impact, you don't have to take any more. So I'm not giving you a definitive answer as to lifetime, 15 years, 20 years, 10 years, although the evidence is suggesting that 10 years is superior for most people. Incrementally small, past 5 years, but very real, and something that again, we just have to watch the data evolve and really stay on top of that. So it's a very important topic, and science informed. Other questions? Mike back here, please.
Hi, I actually have 2 questions for you. The first one is anybody here studying thermography as a screening tool versus mammograms and the effectiveness? And if you're not studying it, then why? And then my second question is about supplements.
You say thermography?
Thermography.
Okay.
And my second question is about taking supplements during chemo. Very close friend just went through 8 weeks of chemo, was not permitted to take even vitamin D. And why is that the protocol when there are many studies showing the effectiveness of supplements keeping people's immune systems strong and also making chemo possibly more effective?
Okay, boy, that's like an hour's worth of answer. But rather than sort of pontificate here, I think who wants to handle the first part of it, which is thermography?
So,
and by the way, my colleagues are sitting here so quietly. Raise your hand. I don't necessarily. If you want to make a comment about this, let us know. But meantime, Sylvia's going to get into that.
There is a lot of, and there should be more and more research on figuring out better ways for early detections. And mammography is a very solid way for early detection, and we have to definitely use it. But improving mammography or complementing it with other modalities certainly is a huge area of research. And to my knowledge, quite a bit of funding from NIH, for instance, goes to develop new tools for early detection of cancer in general, particularly breast cancer. So no question, and early detection, we all want early detection, no question about that. To my knowledge, there is no evidence that thermography adds. So it means, unfortunately, you really need to have very strong standards before you implement a change in the practice of medicine, because there are a lot of costs, not only of the modality, but also the time that a woman has to be subjected to. So you need to have studies where you really compare adding thermography to mammography and show the yield, not only of whatever you find, but the fact that you find really the lesions that are cancer, not lesions that are benign, because otherwise they may trigger more biopsies. So in the biopsies, if they're all negative, you do more damage than help. So it's very careful how progress in early detection is screened and any progresses. But definitely, we know that thermography can pick up, particularly with tumors that are relatively superficial, changes in the temperature, because the temperature is a surrogate, an expression of the metabolism, and cancer cells proliferate faster and consume sugar and other nutrients faster. So you see they're hotter somehow with thermography. So it's not that it's not sensitive, it's whether it's specific and it adds to the yield of finding true cancers.
Yeah, I mean, that's my study of it as well. First of all, it tends to find larger tumors than you find by other things like MRIs, for example. We find much tinier tumors, but also you get a lot of false positives. And basically you just know that there's some area that's hot, so it leads to a lot of unnecessary biopsies. The question on supplements comes up all the time as well. And I just before we get other people, I just want to sort of this, take supplements because it stimulates your immune system and that's good for you, all right, is a marketing slogan. It's not a scientific statement, okay? It's one of those things that kind of makes sense, kind of intuitively, without any supportive evidence behind it, all right, in that regard. And we're talking about the importance of T cells in the tumor and fighting the tumor, but there are white cells that support the growth of the tumor also. And so non-specific stimulation of the immune system. Remember, that, chronic inflammation is carcinogenic, and that, that's chronic inflammation means white cells. They're in there doing something bad, not something good. So, and then you got to go to, can taking supplements, sort of as a general kind of thing, change white cell function is another question that's embodied in that. I'd like to throw that out to somebody else here, so I don't just keep talking. Do you want to, Hope, do you want to? Okay, oh yeah, please, that'd be, and then Hope, I make a comment too about that. Joyce from Miami.
Hi.
Could you stand up so they see you?
So I'm a medical oncologist, and I will acknowledge that there are a lot of things that we don't understand about our therapy of cancer. And I don't think there's a hard and fast rule about vitamins and whether you should use them with chemotherapy or radiation therapy. In general, taking vitamin D3 is a good thing for our bones, and we should do it. One of the things I caution patients about is that there are many supplements. So I'm going to talk about two things, which are that grab bag of unknown supplements and vitamins. So with regard to vitamins, many vitamins work by opposing oxidative cell damage. And so in general, they might be good for us, but we're not really sure and in what doses. During chemotherapy and radiation therapy, one of the things that is assisting in the death of your cancer cells are oxidative cell damage, and vitamins might, in theory, potentially oppose that. So I tend to caution patients and say, while you're on your chemo or your radiation, maybe you should just put those on hold for now, because we don't know whether theoretically they might slightly oppose the effect that we're trying to accomplish. So that's one thing. And then the other thing is that be aware that if you're taking some kind of herbal tea, it could potentially interact with your chemotherapy in a bad way. And because we don't know what these herbal remedies comprise, and they're not all innocuous, some can actually cause damage to the liver and cause irritation of the liver, or potentiate a damaging effect that some of your traditional therapies that your doctors are giving you. So for that reason, I tell people to really be very cautious about using undocumented or even just vitamins when they're taking their cancer treatment. So it's not a hard and fast rule, it's not an absolute protocol. Many clinical trial protocols absolutely require that you stop your supplements because we have no clue whether they might cause harm when combined with a new drug that we're testing.
Hope?
Hope Rugo at the University of California, San Francisco, where a lot of people take supplements, as you know. So I think that explanation was very elegant. And I think one of the things about supplements is that it adds to the sense of control in a situation which is out of control. So you don't control getting cancer, you don't really control the treatments, you're scared, you want to do everything you can. And some research has actually suggested that if people have that sense of control, they have a better sense of well-being. But we want to balance that against what's right for you. So the things we hear are, I want my immune system to be healthy. Most of the women I see have a very healthy immune system. It's unusual for us to see very sick people whose immune system is weak. And as you heard earlier, it's not that if you make your immune system stronger, you're going to get rid of that cancer, because the cancer has been able to escape with its invisibility cloak. And what we're doing with chemotherapy is actually, in some situations, revealing the cancer to your own immune system so that it can more effectively attack the cancer. It's not just global cell kill, it's actually that part as well. So the supplements aren't going to do that. They aren't, in general, going to help you kill the cancer. And then, of course, this issue about potential interactions is important. If you believed that very high dose vitamin C was going to protect your cells, you probably don't want to protect the cancer cells. And vitamin C doesn't really know what cells it's going to protect or not. So I always tell people, don't take it around the chemo or maybe during the chemo, but wait till afterwards. You have to understand interactions with hormone therapy. And then along with supplements are things that come in little brown bottles or clear bottles, and you really have no idea what's in it. A lot of supplements that are given that, again, might enhance the immune system. And you do have to be very careful because we don't know what's in them. And we know from a study in prostate cancer where men received a very effective herbal combination that when they actually analyzed all the components, it was contaminated with blood thinner, with other agents, pharmacologic agents that we knew treated prostate cancer. So be cautious about what you want to put in your mouth, that you don't know what's in it, because you don't know what it's going to do.
Yeah, well, a lot more we could say about this topic, and perhaps we're going to do that. Let's just do one more question, and then I think, unfortunately, we're going to have to close. So whoever gets the mic first. All right,
Thank you. It's always great to have our white blood count at normal. Chemotherapy affects it, but chemotherapy helped me as well. Without it, I wouldn't be standing here. And when our white blood count goes low, we use the drug I was using, Neupogen, which helped boost the white blood count. And to get it at normal, does that help? Does that, at the same time, can it bring cancer if we bring the white blood so high?
It's actually, Neupogen increases a kind of white cell called a granulocyte, which is very important for fighting bacterial infection, which is why we use it, so you don't get, but the kinds of white cells that we're talking about here fighting the cancer are lymphocytes, which are not affected by that particular drug. But still, there's, the use of Neupogen has been a very significant advance, not only preventing infections, but allowing us to give anti-cancer therapy a better way, proven better way, internationally proven better way to treat the cancer. So the important point about it is it's not harmful in terms of, there was some concern that, just from what you're saying, that increasing white cells may actually have some kind of harm associated with them in terms of developing other cancers, leukemias, or other things, and it's not. So Neupogen plays an extremely important role. We're getting close to the end. Closing comments, like what's the takeaway from this audience about your particular area of expertise, Judy?
Well, I think you heard there are a lot of people working hard on cancer genetics, many of them here to try to help us better identify people at risk and figure out how to help protect them from not only breast cancer, but the different cancers that might be associated. We've had an explosion of information. We have better technologies. We clearly will find ways to make sure that ultimately everybody knows what their risks are, not only for cancer, but for other things as well. BCRF has been there from the beginning, funding this work and funding it through to its logical conclusions. Well, maybe never concluded, but to many of the potential things that came from it that have given us progress today.
Chuck?
I continue to think our technologies will improve. There are other technologies in the omics world that we haven't even touched on here, like proteomics, right? We can now study all your proteins at once. I think we're going to continue in this technological revolution and to incorporate these, and I think this will improve personalized care.
So I would like just to have introduced or have you think about the fact that we now have two targets, the tumor and hopefully more and more in the future, rescuing the individual deficits of the patient's immune system toward that tumor. So 2 different targets. And with the help of the immune system, as Leisha very nicely indicated, if we're capable to bring back the immune system to fight the cancer, we have this additional advantage. The immune system has a memory. Same things when you get immunized, it stays with you for life, right? Or for many, many years. So that memory you can exploit and may help keeping at bay cancer during that sleepy phase, before metastases come back. So maybe the immune system can also contribute to reducing, metastases from growing and mortality of breast cancer. And there we need a lot of help because we're making progress in mortality on breast cancer, but we're all still here fighting the disease because we're not there yet.
My closing comment is my gratitude for all of you for supporting these activities, for being here today. My gratitude to the panelists and to our extraordinary scientists who are right around me. Any one of them basically could sit here and talk for 2 hours and give very, very valuable information. I must say you've all been extremely well behaved today. I've really very much appreciated it. Unusually well behaved. I probably have arrows sticking out my back that I don't know about yet, but nevertheless, it's great to be all in this together. It's great to be making the progress that we're making, and it's great to see you all here at this luncheon today. Thank you all very much.